Next week, we'll have Dr. Jean Bookman presenting to us. This week, however, I am delighted to be introducing Dr. Lauren Baldassarre, one of our very own. Dr. Baldassarre earned a degree in biology from the University of Virginia, and then subsequently earned a master's in physiology and biophysics from Georgetown University. She subsequently stayed at Georgetown, where she completed her medical degree. She moved then north to New York Presbyterian Weill Cornell, where she received her internal medicine training, followed by cardiovascular medicine training at Georgetown University. And then she moved back up to New York for a focused year on both cardio-oncology and advanced imaging at Memorial Sloan Kettering. We were lucky to recruit Dr. Baldassarre directly out of fellowship to Yale, where she has been since. She has done a tremendous amount of work in growing our Cardio-Oncology Program here at Yale, and she has served as its director since 2015. She additionally serves as the director of the Cardiac MRI CT program for cardiology, and is associate professor of cardiovascular medicine and radiology and biomedical engineering here at the Yale School of Medicine. She has a special focus, interest, and expertise in the intersection of immune checkpoint inhibitor toxicities and multimodality imaging. And it is with great pleasure that I hand over the podium to Dr. Baldassarre. Thank you very much.
Great. Thank you so much, Dan, for that kind introduction. And it's really a pleasure to speak with everybody this morning about cardiotoxicity from immunotherapy. And we'll be addressing the question, can advanced cardiac imaging meet the challenge? And I hope that I can convince you that it probably can. So I have no relevant disclosures. So I think we all know that there's multiple different types of therapies from cancer that can cause cardiotoxicity, and this can result, via multiple different pathways, can result in direct cardiomyocyte damage, vascular endothelial dysfunction, arrhythmias, fibrosis, etc. The list goes on, and we're not going to go through all these today, and we're going to focus on immunotherapy and specifically immune checkpoint inhibitor therapy, as this has really been revolutionizing the field of oncology and therefore cardio-oncology. And without going into great detail, just explaining a little bit about what these agents do. And essentially what they do is they allow the T cells, they allow the one's own immune system to kill tumor cells, to fight the cancer at hand. And these normal pathways that they inhibit are pathways that work with the checks and balances of the immune system, which are normally good. They can help to prevent things like autoimmunity and to downregulate too much inflammation. But what they can unfortunately also do is allow for tumor evasion when there is cancer present. And so these agents work to block this pathway, the PD-1, PD-L1, and also via CTLA-4 to essentially rev up the immune system and allow the immune system to attack cancer cells in a more efficient manner. And so it's very important to understand that these types of agents are really improving survival in many different cancers. And this is just one example here from one of the keynote studies in non-small cell lung cancer. And you can see on the left in the blue line, patients that received pembrolizumab, which is an immune checkpoint inhibitor in combination with chemotherapy, had significantly increased survival compared to those that did not. And as well, as you can see on the right, this also was, they had increased, survival without disease progression, which is also important. So this is not meant for you to read this, but just to kind of see the different agents that have already been FDA approved as far as specifically anti-PD-1 and anti-PD-L1 antibodies. And you can see along the top here that there's more than 20 cancers in which just specifically these agents alone have FDA approval for use. But even more importantly, what is demonstrated here, and this was updated as recently as November 2020, so just a few months ago, there's actually currently over 4,000 clinical trials utilizing these agents. And what's demonstrated in this bar graph here with the colored bars is that these agents are being used very often in combination with other therapies, which we know have potential cardiotoxicity. So this is really, really important for the field of not only oncology, but cardio-oncology as well. And as you can imagine, as I previously described to you how these agents work, that, the upside is what we've discussed, but the downside is that unfortunately, this can lead to too much inflammation and autoimmune type of reactions in really any organ system of the body, as demonstrated in this image here, and up to requiring discontinuation in about 40% of patients, requiring treatment with immunosuppressants such as steroids and other therapies. It's been reported higher with anti-CTLA-4 agents, as well as higher with combination therapy. It's been reported that over 3% of these can be fatal. And of those that are fatal, 10% has been cardiac. So the clinical presentation of cardiac toxicity from these therapies can actually be quite variable. You can have, as what's seen here, sort of fulminant myocarditis with a classic T-cell infiltrate seen on histology, malignant arrhythmias, heart block, stress-induced type looking cardiomyopathy, and also potentially atherosclerosis and acute coronary syndrome, as well as vasculitis. And this iceberg image here just illustrates nicely the concept of accelerated atherosclerosis with these agents, which we'll touch on a bit later, that we're just really now literally just seeing the tip of the iceberg. So I think many of us are familiar with the initial landmark study that demonstrated 2 cases of fulminant myocarditis with these agents, demonstrating a lymphocytic infiltration. In these cases, both cardiac and skeletal muscle were involved. And the tissue did have increased expression of PD-L1. So the early trials, reported the incidence of myocarditis as incredibly low as 0.09%. However, more recent multi-center study has reported this as just over 1%, and almost 50% of those patients having a major adverse cardiovascular outcome. And then a more recent large nationwide study reported myocarditis as just under 2% in a subset, and actually the total amount of cardiovascular events up to almost 10% in these patients. And this is that Danish nationwide study, which looked at thousands of lung cancer and melanoma patients and just over 1,000 receiving immune checkpoint inhibitors. And what you can see here, specifically for PD-1 inhibitors and lung cancer, that the hazard ratio for a cardiac event within the first 6 months of receiving therapy was greater than 2. And that continued after treatment for 6 months. So that hazard ratio was an increased risk was sustained. Similarly, this was seen in malignant melanoma with even higher hazard ratio, greater than 4%. And also this was seen within melanoma with the CTLA-4 inhibitors as well. So over time, the WHO database has noted a significant increase in incidence of events, and about half of these resulting in death. This is likely a reflection of obviously increased use of these agents, but also increased awareness of these cardiac effects, and therefore increased reporting. And meta-analysis has looked at clinical trials and found that 10% of ICI treatment-related deaths were cardiovascular. Another meta-analysis of specifically non-small cell lung cancer patients reported cardiac events of just over 5%, and a single center study in those patients of just over 11%. So obviously this has been underrepresented in clinical trials. So, the question being, what is the true incidence? And the sort of short and obvious answer is we don't know. Trials did not prospectively monitor for cardiotoxicity. It's obviously higher than originally reported in those trials. And data has been coming out over the recent years to really help us understand the presence and the extent and the type of cardiotoxicity. And moving forward, most likely a multimodality imaging and serum biomarker approach is really going to be what's needed to diagnose and manage this disease state. So as I go through some of the recent data in this field, I'm going to highlight this with a challenging case of ours that's actually a very atypical type of case, or at least a non-classic presentation that I think really highlights the variability of the disease. So this is a 62-year-old man with history of recurrent metastatic melanoma who otherwise was completely healthy on combination immune checkpoint inhibitor therapy, as well as an additional agent on a clinical trial, who presented to his oncologist with epigastric pain. So she checked LFTs that were elevated with an AST predominance, also demonstrated an elevated CK. That elevated CK then prompted the checking of a troponin, which you can see here was mildly abnormal at 0.08. And so obviously there was concern for myocarditis. This is that patient's EKG. You can see on the left, the baseline, and on the right, the EKG after biomarker elevation, that really there's no significant acute changes. I'll make a comment about the use of troponin, which, yes, may be a sensitive early marker for cardiotoxicity, but at this point, the specificity and the prognostic value really isn't known, and there are not currently published large trials, although people are looking at this. There is one small study that did serially check troponins in lung cancer patients on nivolumab, and actually what they found was about 10% had a positive troponin. However, they reported only one patient was diagnosed with a subclinical myocarditis, and they also suggested that potentially other comorbidities may be contributing to the positive troponin, as seen in the bar graph on the left here, where patients who had positive elevated troponin were increased in the group that was had some very high cardiovascular risk factors. This is one of the original retrospective studies in a small cohort of patients who showed that the onset of the myocarditis is relatively early, within the first month, but about half of patients had no other immune-related adverse event. Here, nivolumab was the most commonly used. And again, combination therapy was more frequently associated with myocarditis. But importantly, what I'll show you here, if you look at figure B, ECGs were abnormal in a majority of patients, but not all. Similarly, troponin abnormal in a majority of patients, but not all, as well as proBNP. But importantly, if you look at figure D, you can see that the left ventricular ejection fraction was normal in about 50% of these patients. Here, they used a cutoff of an LVEF of 50%. So as far as echo findings in these patients, it's been quite variable, from depressed EF to normal to wall motion abnormalities to not. in that case series we just looked at, the EF was normal in about 50% of patients, which I think really highlights that just structural and functional assessment with EF alone is not going to be sensitive enough for detection of disease in these patients. And perhaps more quantitative functional assessment with echo, such as strain, the assessment of myocardial deformation may be helpful. This has certainly been utilized in other agents such as anthracycline-based agents in the field of cardio-oncology for early detection of preclinical LV dysfunction. There's some limitations, variability with vendors, software, loading conditions, et cetera, but this does have promise, and there is data in the field for this. And this is just an example of strain assessment by echo. And so specifically in immune checkpoint inhibitor myocarditis, there is one study, a retrospective study, looking at global longitudinal strain by echocardiography. And what this showed, as seen on the left here, in the small subset that had baseline echoes, in red, you can see those who developed myocarditis versus blue controls, and there was no significant difference at baseline. However, in the middle panel, you can see in red, those that developed myocarditis had a significantly lower global longitudinal strain compared to controls in blue. And interestingly, on the right, you can see that those with myocarditis and a reduced EF, of course, had decreased strain, but those with a preserved LVEF also exhibited decreased global longitudinal strain compared to controls. So perhaps this is highlighting this is likely a more sensitive marker for preclinical dysfunction. So going back to our case, so this patient actually didn't have an echo. Interestingly, the MR just happened right away, so went straight for MR. And what you can see here are the Cine MRI images, a two-chamber view on the left, and a short axis view on the right. And this patient had calculated normal left ventricular ejection fraction at 64%. This is their delayed enhancement MRI seen on the left, where there's a little bit of sort of mid-myocardial delayed enhancement. Also, with the arrow, you can see a little bit of pericardial enhancement of the lateral wall. And then on the right, you can see the T2 map looking for edema and inflammation with a small focal area in the mid to apical anterior wall with increased T2 signal. So cardiac MR has really been established as a primary tool for the diagnosis of clinical myocarditis. And we use something called the Lake Louise criteria, which looks at both T1 and T2 weighted imaging to make this diagnosis. So based on the images I showed you, our patient would make a diagnosis of myocarditis, and in this case, myopericarditis. More updated criteria have included more quantitative parametric mapping techniques, as shown here with T1 mapping, also extracellular volume calculation, utilizing both pre and post T1 mapping for calculation of that value, as well as T2 mapping, which our patient did have. So as far as cardiac MRI findings specifically in ICI myocarditis, some of the initial reports utilized MR, but the findings weren't very clear. That retrospective study I showed you reported a non-ischemic scar pattern in about 71% of the cases in that small cohort. However, more subsequent data has come out, and this is a retrospective study that's international and multi-site with just over 100 patients, 23 sites, and about half of these had endomyocardial biopsy, and the other half, the diagnosis was a clinical diagnosis of myocarditis. The studies were read clinically at each site via qualitative reads for late gadolinium assessment and visual assessment for T2 increased signal, and therefore has been appropriately referred to as a real world study. Interestingly, in this study, they reported just under half of patients had late gadolinium enhancement, and just under a third had qualitatively abnormal T2 weighted imaging. And also interestingly, you can see on the right here that the late gadolinium enhancement actually was not predictive of major adverse cardiovascular events. There was a very small subset of patients that did have T1 mapping and showed some signal there of increased values, both on pre and post contrast mapping. And so I think this was a nice study that highlighted that qualitative cardiac MR assessment may be somewhat limited, and future study with more quantitative techniques is needed. And there's a large body of literature in cardiac MR and myocarditis over the last about 15 years or so, demonstrating its value. And this is just one study here of just over 200 patients with, this is just general myocarditis, not immune checkpoint inhibitor, but biopsy proven. And other studies have shown this as well, but I'm just highlighting this one where they did show that presence of late gadolinium enhancement had significantly increased hazard ratio for all-cause mortality, as seen here in the blue line on the right, compared to those without. And in this study, no patient without late gadolinium enhancement had sudden cardiac death. So that's somewhat contradictory evidence compared to what was presented in the prior study. And there was a nice editorial on that prior study by Matthias Friedrich, who wrote the white paper on the use of cardiac MR for myocarditis and established the Lake-Louise criteria. And I think, he also kind of mentioned we should be a little bit cautious about drawing conclusions on the utility of MR from that study due to the limitations we mentioned. But what I would like is what he described here, which is that, he said ICI-related cardiotoxicity is a result of a disease process in varying location, variable severity, variable associated findings in various cardiac structures. And I think that pretty much hit the hammer on the nail there, demonstrating the complexity of this disease. And so this is our subsequent study from our institution here, where we did apply quantitative analysis of T2 ratios, percent LGE, feature tracking strain by cardiac MR in a cohort of patients identified with immune checkpoint inhibitor cardiotoxicity. And what you can see in the bar graph on the left is that time to presentation in our cohort was quite variable. And what you can see here on the right is that the presenting symptoms were also quite variable. And actually about a third of patients presented really with more respiratory symptoms than classic cardiac symptoms. And I think this is for various reasons, but one of which is that the majority of these patients are sick. A lot of them have lung cancer or lung metastases from other diseases. And that can really confound sort of the clinical symptoms and picture, making, again, the presentation relatively complex. So in this study, what you can see here, we applied on the top T2 ratios, which is looking at the ratio of the signal intensity in the myocardium to the signal intensity of the muscle within the same image. And what has been shown and established in prior studies, and part of the criteria is that when that ratio is greater than 2, that is consistent with increased edema or inflammation. And you can see in the panel on the bottom here on the left, some mid-myocardial delayed enhancement that can be visually assessed. But in panel B on the right, you can see when quantitative analysis is set here, where we use 6 standard deviations above the normal reference point to detect late gadolinium enhancement in our study. And we also found that 50% of patients had a normal LVEF, which we used a cutoff of actually 53%. And 85% met at least one criteria for Lake-Louise, which is highly supportive of myocarditis in the right clinical context. and almost half met definite myocarditis. We also identified an additional 2 patients with acute MI. The average amount of late gadolinium enhancement was just over 9%, and the average global longitudinal strain was around -10, -19 being the cutoff for normal, similar to echo. And this is an example of a case as shown here with increased T2-weighted imaging, relatively diffuse, but more concentrated within the kind of anterior and lateral walls. And with quantitation, this did quantitate at greater than 2. And then here's the subsequent delayed enhancement imaging in this patient, which shows clear mid-myocardial delayed enhancement in a non-ischemic pattern. This is the feature tracking strain analysis on the cardiac MRs, again, showing on average a global longitudinal strain that was significantly decreased around -10. But interestingly, in those with a preserved EF, the global longitudinal strain remained significantly depressed around -12. And when we looked at the difference in those 2 groups, the difference was significantly depressed in those with a depressed EF. And this is just one patient example seen here in the bottom left, in a patient that had a completely normal left ventricular ejection fraction, but abnormal strain, as well as positive late gadolinium enhancement, just highlighting tissue characterization and more advanced quantitative assessment above LVEF. This is a study here, and this is work done by one of our current faculty, Dr. Cecia Gallegos-Totan, that was a case of an unfortunate young patient who presented with ICI myocarditis. And what we had done on autopsy was sampled areas of myocardium specifically that showed delayed enhancement, as seen here on the right, which was mid-myocardial and epicardial. And the corresponding histology did confirm increased inflammatory cells in those areas, as well as increased fibrosis. And this is just to highlight the variable presentation of ICI cardiotoxicity from this study, where we did also show acute MI in a couple patients. And you can see that in the panel on the top, with the arrow pointing to near transmural delayed enhancement with a central area of microvascular obstruction, and the T2 map with corresponding increased edema and inflammation, as well as patients who can present with a quite severe pericarditis, which is often associated with a myocarditis, at least even a subclinical one, but can also be isolated. And that's shown in images here on the bottom. You can see the arrows pointing to very thickened and fibrotic pericarditis patient. And then also we've had cases of direct tumor infiltration, and this is a case of that shown here, where there's tumor throughout the myocardium of metastatic disease, in this case renal cell. And you can see on the right with the T2 map that there's areas of increased signal and inflammation with the tumor. And I think it's unclear if it's just inflammation from the tumor versus a true toxicity versus the therapy doing what it should be doing. But regardless, this patient did die from heart failure due to this complication. And so this has prompted, this has prompted us to follow patients who've had a similar type of presentation. And this is a nice case presentation recently presented by one of our fellows, Dr. Jason Cuomo, as well as with involvement from Dr. Sarah Hull at our recent National Cardiac MRI meeting, showing a patient who we serially followed. You can see in the upper left, this patient was diagnosed with metastatic disease in the apex of the myocardium. That's their baseline MR. In the middle image, you can actually see that there's really nice tumor response with immune checkpoint inhibitor therapy. This patient had a non-cardiac immune-related adverse event for which their therapy was held. And you can see in the bottom right that with that therapy being held, unfortunately, there was significant regrowth and infiltration of that tumor. And so most likely moving forward, more quantitative T2 weighted mapping techniques will be utilized for sensitivity for inflammation. And that's demonstrated in this panel here. In the middle, you can see the T2 map where the arrow is with increased signal intensity in the septum. If you look to the corresponding traditional T2 weighted image on the left, I think it's really not as clear. And then on the right, you can see the corresponding late gadolinium enhancement with clear LGE in that area. Another area for potential more increased sensitivity for detection of disease is going to be with T1 mapping. T1 mapping is something we do where we acquire a series of what's called inversion recovery images using pixel-wise curve fitting. We then create what you see here is this nice T1 map, which gives us the T1 weighted values on really a pixel by pixel basis, from which we can put region of interest in certain areas or throughout the entire myocardium. That then gives us this more quantitative T1 assessment. And this has been validated in multiple different disease states, including myocardial infarction. You can see here that the T1 maps correlate to areas of LGE, similarly in the middle in amyloidosis, as well as in the bottom in other non-ischemic cardiomyopathies. And I think what would be interesting is to see if we can monitor disease extent with this type of technique. And this is a different disease state, amyloid, and this is work done by our current faculty, Dr. David Herb, where we looked at a patient with amyloid, and this is actually without contrast. This is native T1 values. You can see on the left were elevated, consistent with amyloid involvement, and as the patient was serially followed with treatment, you can see that those T1 values decreased over time. And on the right, you can see that those values decreased with, correlated with decrease in serum biomarkers, BNP, their light chain ratio, as well as LV mass, and importantly with patient clinical course, which did improve over time. And so I think if we could apply something similar to this disease cohort, that could be helpful. There are some other strain techniques besides feature tracking that we can do with cardiac MR, such as tagging sequences seen on the left and SANC signal encoded on the right, which takes advantage of the difference between high tuning and low tuning in contracting cardiac muscle. These may be more robust techniques. They do require a dedicated sequence and some more complex post-processing. But they are showing some promise in the field of cardiotoxicity and actually in heart failure in general as well. And this is an example here of a pilot study that we did utilizing that fast SANC strain imaging in a cohort of patients with immune checkpoint inhibitor myocarditis, as seen in red versus controls in black. And this is work from our fellow, Dr. Jason Cuomo, which was, as well as some of our other fellows contributed to this. That was also recently presented at our National Cardiac MRI meeting. And what he showed here was on the bottom bar graph, you can see that there are significant differences in the global longitudinal strain, as we've seen in the prior studies between the two. But interestingly, on the right, when you break it down into segments, there's a significantly increased amount of dysfunctional segments in the ICI myocarditis group versus controls. And on the right, you'll just see a report here of what that type of analysis looks like with the segmental approach. So back to our case, you saw the cardiac MRI. The findings were somewhat subtle, but true in there and did meet criteria for myopericarditis. And then the patient subsequently developed a chest pain, albeit atypical, and with a troponin that continued to peak at 0.11. So at this point, we also ordered a coronary CTA for non-invasive assessment of atherosclerotic coronary artery disease. And what you're seeing here are the multiplanar reformatted images of his coronary CTA with the left anterior descending artery, left circumflex, and right coronary artery laid out for you. The left circumflex and right coronary artery looked relatively normal. What you can see here on the left, that's zoomed in on, is the LAD, where you can very clearly see an area of non-calcified low attenuation plaque with at least a moderate stenosis. And so we performed further analysis on his coronary CTA with non-invasive FFRCT, fractional flow reserve, which has been validated against invasive FFR as is done in the cath lab. And similarly to invasive FFR, we use a cutoff of 0.8. And you can see here in the red that that lesion corresponded to an FFR of 0.5. Here's the angiogram in the middle. You can see similar corresponding LAD lesion. And then on the right is a snapshot of that lesion. So he did receive a drug-eluting stent for this. So there has been some recent study looking at and really, quite frankly, confirming what we thought we already knew and have seen in multiple patients, that ischemic cardiovascular events are associated with immune checkpoint inhibitor treatment. And you can see on the left here, so this is a case crossover study looking at 2 years before and after ICI therapy. And you can see on the left, the blue pre-immune checkpoint inhibitor, and on the in the red, the post-immune checkpoint inhibitor, with significantly increase in composite cardiovascular outcomes, as well as MI, revascularization, and stroke. And what you can see in on the right is, again, in red with immune checkpoint inhibitor versus similar patients who were not treated, significant increased hazard ratio for cardiovascular events. There was a small subset of that study that looked at CTAs and specifically looking at plaque volume in the aorta. And what they showed was that there was plaque progression after initiation of immune checkpoint inhibitors, and also specifically progression of non-calcified plaque, similar to the plaque we saw in our patient in the coronaries. And so, obviously there is concern for ischemic disease and acute plaque rupture in checkpoint inhibitor cardiotoxicity. There's many experts in our section who have dedicated their careers to this and have a greater understanding of this. But in general, the concept is that, as we discussed previously, this pathway is important for downregulation of inflammation, and when it's disrupted, it can lead to increased inflammation, which can lead to increased pro-inflammatory and pro-atherogenic cytokines that could potentially lead to plaque destabilization and or plaque progression. And this is just a small study on the right that looked at patients not with myocarditis, but just treated with ICI, showing that treatment did alter the inflammatory profile of the plaques in those patients. So back to our case, before his left heart cath, the day before, he did also have a biopsy because of the unclear presentation, which was reported as normal. And so just a bit about biopsy, you can see on the left here, this is a small study of 10 subjects where they, by histology, put into 2 categories of high grade versus low grade. And this, did correlate to clinical outcomes in this small cohort, showing some promise. for looking at biopsy to help us understand the amount of disease. However, I think just caution the sensitivity of RV endomyocardial biopsy for ICI myocarditis specifically really is not known. And I think we're all aware there's not a lot of great data in general for biopsy. And this is very old data, but it's in lymphocytic myocarditis, and using autopsy histology, which is obviously the true gold standard, and comparing biopsy to that, the sensitivity was actually quite low in the 40s. So, this disease can be patchy. In a lot of cases, getting the biopsy is important, but we do have to have caution that we have to put the whole clinical picture in context as well. And so back to our case, so we kind of did a in-between type of approach after many lengthy discussions with the patient, his family, and the oncologist, where we decided to hold immune checkpoint inhibitor therapy, but we also did not give any immunosuppressants. He did have resolution of pain after the coronary stent, and however did continue to have a low level troponin, and this is somebody with normal renal function, normal cardiac function. On his repeat cardiac MR, which you see here in the top, the T2 is normal, so resolution of that inflammation. And on the bottom right, you can see still some areas of LGE that were stable, didn't progress, but actually he had a new small pericardial effusion and also some delayed enhancement. However, he remained clinically stable and asymptomatic and was eventually rechallenged with single agent, and has been doing well over the last couple months, and we're following him very closely. So I'd like to bring your attention here to some recent algorithm that has been put out by the ACC. Prior recommendations have been really mostly oncology based, and at this point, after a few years, are really outdated, that just recommended stopping and never giving again immune checkpoint inhibitors for any of these patients. But obviously we're seeing now that there's variable presentation, and so what they've done here is sort of grade them from sort of a mildly abnormal, low level up to severe. And they're still relatively vague, but they do give us a little bit more guidance. And so for this patient, we kind of put him in a grade 1, although you could argue he's sort of a borderline grade 2. But regardless, we did resume, after very close monitoring, resume ICI with continued monitoring in this patient. So I think you can see that there's sort of a changing paradigm of cardiotoxicity assessment with the introduction of these agents. And the question is, how will the role of advanced cardiac imaging and specifically cardiac MR change as the field of immuno-oncology grows? And I think really we're going to need more tailored algorithms specifically to therapy rather than a one size fits all type of approach. And so I'll just bring your attention here to the document that we primarily refer to for monitoring for cardiotoxicity, which is also a little bit quite old at this point, from 2014, but using primarily 3D echo and consideration of cardiac MR in certain circumstances. That's really focused on LVEF assessment and does also include assessment with global longitudinal strain, but it's really mostly focused on anthracyclines and trastuzumab therapy. And the definition of CTRCD, cancer therapeutic related cardiac dysfunction, from this document, which most people follow, is a decrease in EF of greater than 10% to a value of less than 53%. And obviously this type of approach is not going to cut it for this evaluating ICI cardiotoxicity. And we won't go through this, but this is just to show you, our advanced cardiac imaging algorithm here at Yale for our cardio-oncology patients, and which is similar to the ASC one I just showed you, but with more liberal use of cardiac MR in certain circumstances where diagnostic echo cannot be obtained, or if there's mildly abnormal dysfunction that we need to corroborate or of course, when there's decreased function, then we would want to use that for cardiomyopathy workup. And then we also utilize nuclear imaging in certain circumstances as well as stress MR. And this just sort of highlights, we sort of looked at our initial data when we introduced cardiac MRI into this algorithm. You can see on the left in the green bars, obviously, as expected, there was a positive association between successive years and cardiac MR use in this patient population. And I think also interestingly on the right, you can see, of course, echocardiography remains the backbone of this assessment over those years. However, it did significantly slightly decrease, which I think is fine because it probably shows appropriate selection of testing rather than just over testing and over imaging of patients. And I think we have to give at least one slide and talk about COVID a little bit. So I'll just sort of bring your attention to this document that we put out from the ACC, Cardio-Oncology and Imaging Councils, which did give some guidance on modifications to assessment during the COVID-19 pandemic. But as I think you all know, cancer care and cancer therapy continued almost as usual. And so we've really recommended continued surveillance with some minimal modifications to limit exposure when not necessary for patients. And then lastly, I will just bring your attention to the obvious potential role for cardiac PET in ICI cardiotoxicity. There's really minimal clinical data currently in this field, but this is a published case that did demonstrate, as seen on the left here, in a patient with ICI myocarditis, increased signal. And after steroid treatment, you can see on the right that that did decrease. And then, of course, there's a significant opportunity here for PET molecular imaging using targeted PD-L1 for looking at tissue expression, and then potentially even specifically looking at anti-PD-1 in T cells and monitoring movement of T cells in disease diagnostic and monitoring potential here. So. And I also will just say, we focused on immune checkpoint inhibitors today, but and they're the largest group, but there's actually many other groups of immunotherapies that can have similar types of effects. And I won't go into detail on this. This is work that's been done by Dr. Jennifer Kwan, which she will go into further detail at her presentation soon, where we saw that there were cardiovascular events in this agent, which is a monoclonal antibody to CCR4 and T cells. We saw cardiac events and myocarditis, prompting us to do a WHO Vigibase study, where we saw that just over 4% of reported events were cardiac, and most of those were actually heart failure and ventricular arrhythmia. And what she nicely showed here is that fatal events, which are the red circles, actually happened, quite early. And so I think just highlighting the potential toxicity of many other types of immunotherapies. So, retrospective imaging and clinical data is somewhat limited, but definitely suggests a variable clinical presentation for immunotherapy-associated cardiotoxicity. Advanced cardiac imaging, really, of course, especially MR, but really multimodality, is a helpful tool to diagnose myocarditis and other cardiovascular disease states. And we definitely need further prospective study to assess diagnostic accuracy and prognostic value of these imaging and serum biomarkers. And we have some ongoing study currently in this area. And I just really want to acknowledge our prior and recent prior and our current advanced cardio-oncology and imaging fellows, specifically Drs. Jennifer Kwan and Dr. Jason Cuomo in cardio-oncology, as well as advanced imaging, and Dr. Attila Faher in advanced imaging, who contributed to some of this work as well. And our recent prior fellows, specifically Dr. Angela Higgins, who did a lot of the immune checkpoint inhibitor work, and Drs. Ahmed Arboon, Aaron Sufer, and Krishna Padaya as well. And then finally, just acknowledge my colleagues and collaborators in the field here at our institution, specifically our cardiac MRI and CT section, and highlighting Dr. Hamid Mojibian as well, and our Yale Cardio-Oncology Program. And really, I can't say enough about Dr. Sarah Hall and Jessica Coviello, our advanced nurse practitioner, who have been just amazing partners and colleagues in this program, as well as my collaborators in the Magnetic Resonance Research Center, specifically Dr. Dana Peters. And there's many, many others, and I've listed some here in the middle within our section, not in order of importance, but in alphabetical order, who really have just contributed, supported very much my career, my clinical and research endeavors since I came here, and has made my early career at Yale a great one. So I just want to thank everybody. And I think hopefully we have a little bit of time for questions and discussion. And it's really been great to share this with you today.
Thank you, Dr. Baldassarre. Very impressive body of work, and very impressive how you've built up the Cardio-Oncology Program in your time here, both from a clinical and a scientific perspective. So we certainly do have time for questions. It looks like Dr. Zaret has a question. So if you'd like to unmute yourself, please feel free to ask.
Thank you, Lauren, for a very exciting and interesting talk. It's kind of interesting for me to hear this. Over 40 years ago, we first described in the New England Journal an approach to deal with anthracycline cardiotoxicity that formed the basis for a lot of what's happened since, at least 30, 40 years. And in that study, we emphasized the importance of sequential studies. And I wonder if you have much experience with sequential studies with MR. I have two other quick related questions. Are there any studies out there looking more specific? Well, you mentioned some at the end, but other studies looking at specific inflammatory markers, such as labeled cell imaging. And also, a long time ago, there's an extensive literature on anti-myosin antibody for looking at cardiac transplant rejection. Has that been, or can that be resurrected? And finally, with all of these large studies, are there whole genome studies looking at any potential genetic reasons for specific vulnerability for checkpoint inhibitors in the heart, since it's a relatively uncommon phenomenon?
Sure. So, I completely agree with you that prospective serial imaging is what's needed, in this case, and we are, there are not any published studies of serial MR imaging in this case. However, we are doing some here, and I'd just like to highlight, we're doing this in symptomatic patients. So please, obviously from a clinical standpoint, if any of these cases, we would hope that everyone would reach out to us to kind of get our input and help where we can on these cases, but then also to refer these patients to us as an inpatient for their asymptomatic studies, which we're enrolling patients in, and then we're doing subsequent follow-up with cardiac MR. And then we're also now just started doing serial prospective studies in asymptomatic patients. So patients doing an MR at baseline before receiving therapy, and then doing sequential imaging to look for subclinical toxicity with a lot of those quantitative techniques that I just mentioned. And I think, you had kind of mentioned inflammatory markers. Some people are looking at this. I've met with others in our section to start a collaboration on looking at inflammation and inflammatory markers in these cases. And I'm sure people are doing, genome-wide studies. And, specifically when we're talking about an immune system, and there's, a potential to look at like HLA typing, kind of similar to what you described. There is some overlap with transplant rejection. But it does appear to be different on some level than transplant rejection. And so I think there's overlap, but on some level, it's a little bit of a different disease state.
Maybe I'll go, Lauren. That was a great talk, and congratulations on all your work. You've clearly become one of the leaders in this field, and it's really nice to see. We've talked about this, you and I have talked about this before. Something that really mystifies me about this area is that there's almost like a default pathway of autoimmunity that checkpoint inhibitor therapy uncovers. So the two parts to that, one is whether anyone has tried to identify maybe a cryptic autoantigen that's driving the immune response that's been uncovered. Barry mentioned anti-myosin antibodies. There's been a theory about myocarditis and so-called cryptic autoantigens being uncovered. And the other, I was really happy to see this PET PD-L1 imaging in its early stages, because as you and I have talked about, are there subsets of patients who have, for whatever reason, really high levels of PD-L1 at baseline in their normal state that repress this kind of default autoimmunity? And if that is something that you think is going to be more utilized before the beginning of CPI, just to see if somebody is more at risk, just de novo.
Yeah, those are great questions as well. We've met, with some potential collaborators in PET imaging, and specifically looking at these this type of targeted imaging. And I'll say in general in the field, with studies looking at concentration of PD-L1 receptors in biopsy to sort of target subsequent therapy, there's actually a lot of very mixed data. And there's, been some data showing that it actually doesn't predict patient response. That probably is due to multiple factors, one of which I believe may be, obviously there's tissue sampling error, but also that there can be different expression clearly in the site that was sampled versus, metastatic disease in other parts of the body. So although that hasn't really panned out as far as looking at the tissue sample to predict response to therapy as much as people thought it would, there's still a possibility, could it predict toxicities? And actually, I do think that's where probably more whole body imaging, specifically, potentially with PET targeted to PD-L1 may be helpful, because looking at, especially in patients with metastatic disease, the whole body, uptake is most likely going to give you a better representation than just a tissue sample, from one site. And, there is a potential role for autoimmune antibodies, and specifically against like troponin, that's been seen in mouse models, like double knockout PD-1 mouse models that develop a autoimmune type of fulminant myocarditis. They have detected antibodies there. And so that's something we've thought about as well, because there are cases with normal troponin that have, the one that we published with the pathology, histology correlate, which clearly had myocarditis, actually had a normal troponin. And I think that's because she actually presented very, very late in her disease and had likely been having heart failure symptoms for months that went unrecognized because of the burden of her lung disease.
Thank you.
I think we have time just for maybe one final question. Aryamani posed a question regarding the role of CRP and cytokines in ACS and canakinumab.
So I think, there is a role for inflammatory markers in not just cardiac, but all of the inflammatory states that can occur, all the immune-related adverse events that can occur from these agents. We've started looking at this. We have a multidisciplinary group within internal medicine that includes obviously oncologists, but also rheumatology, immunology, and specialists that are kind of my parallel in other fields like GI, pulmonary, renal, et cetera, who are looking at their specific toxicities. And, we meet and we have a tumor board specifically on immunotoxicities. And what we've seen is, so obviously inflammatory markers are elevated in patients with cancer. So there's a bit of a limitation there. But following some patients' inflammatory markers and response to steroids has been helpful. And so I think what that has highlighted for us and what we've been trying to do as a group is really establish baseline studies. I think it goes back to the serial assessment is really needed. We need to proactively start with serial assessments of these types of markers and follow them and see how that's helpful to track disease, states over time. Yeah.
Thank you very much, Dr. Baldassarre. Absolutely terrific talk and very impressive how you combine clinical care, science, and strong mentorship. So thank you very much for sharing, and thank you to everyone for joining us today.
Thanks a lot. Take care, everyone.